Good morning and welcome to the Ministry of Health's virtual media conference for Wednesday, 16 June 2021. At these updates, we provide you, the public, with clear and accurate information on COVID-19. At today's media conference, we are pleased to be joined by Dr. Avery Hines, Technical Director of the Epidemiology Division, Ministry of Health, and Dr. Carla Maria Alexander, Lecturer, Immunology, Paraclinical Sciences, Faculty of Medicine, the University of the West Indies. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will be your moderator for this morning's media conference. I now invite Dr. Hines to present the latest clinical and epidemiological updates. Dr. Hines.
Thank you, Mr. Alexander. Good morning to my colleague, Dr. Alexander. Good morning to the members of the media, members of the viewing and listening public. The clinical update is as follows. May I have the first slide, please? As at the 15th of June at 4 p.m., we would have tested at both the public and private facilities. Thank you. 212,899 patients, and out of those, 29,309 would have tested positive. 19,667 will have recovered, and at that time there had been 686 deaths, and we express our condolences to the members of those affected families. There are currently 8,965 total active positive cases, and those are broken down as follows: 459 patients hospitalized, 8,041 in home self-isolation, 138 in step-down facilities, 242 in state quarantine facilities, and as at yesterday, there had been 327 new positives identified. The total persons vaccinated with the first dose of either vaccine stood at 167,027, and those fully vaccinated, meaning first and second dose of the vaccine they received, now stand at 18,506. With respect to the occupancy of the healthcare system, the total occupancy at yesterday's date stood at 54%, with the wards at 50%, the ICU at 76%, and the HDU at 88%. Noting that overall, over the past 7 days, that overall occupancy would have hovered between 54 and 60%, while the ICU and HDU remained above the 75% mark in 4 of the 7 centers that provide clinical care. Moving to the next slide, going directly into the epidemiologic update, we see our familiar epidemic curve, starting on the left with the gray bars representing July to December 2020. And then the colored bars going from January through to the current month of June. We see that the highest of those colored bars, the sort of peak of this most current wave, seems to be between the second and third weeks of May 2021. And we have been seeing lower daily numbers in more recent times as the month of June has progressed. If we move to the next slide, we look at that same data, but we look at it on a weekly basis, and we see that between the weeks, the epidemic weeks or epidemiologic weeks of the week 20 and 21, we saw a slowing or a flattening of the bars, or the change in heights of those bars. So whereas we had been seeing those bars getting progressively taller from the month of March all the way through the month of May, those last 2 weeks in May, that week 20 and 21, we saw that the bars are just about the same height, and that indicated some slowing. Week 22 then became a little shorter, a shorter bar, meaning fewer cases accumulated in that week, and there was a 10% drop. At the end of week 23, that subsequent bar was even shorter, meaning fewer cases again, representing about a 30% drop in cumulative cases over that 7-day period compared to the 7 days before. And week 24 is currently ongoing. And we're currently at 887 cases for the week as yesterday. And we hope that the downward trend will continue. We also note in this graph that the background color, that salmon color, is representative of the percentage of positivity. That's the number of cases or number of samples that test positive out of every 100 that we do a test for COVID-19 on. And that has hovered between 30 and 35% over the past couple of weeks. And the percentage represents not the percentage of or the prevalence of the virus in the population circulating, but really the prevalence of the virus in that higher risk or higher probability group that we sample. People with symptoms, people with contact, etc. And the fact that that is going down is then reflective of the fact that the overall population prevalence of the virus is also beginning to decrease slowly. Next slide, please. If we look at this same data aggregated on a monthly basis, we see that the month of May accumulated over 13,000 cases. The month of June is halfway through and hopefully not proceeding at the same speed. We are also looking at the overall positivity on a monthly scale, and we see that for the month of June so far, the overall average positivity has been about 35% as compared to 43% in the month of May. So indicators of hopefully some encouraging or positive trends. Next slide, please. If we look at the demographics, the left side of this slide shows us what we call a demographic pyramid, showing the male and female positives by 5-year age groups. We see the widest part of that is really that part in the middle that occupies the 25 to 49-year-old age group, and that the male and female numbers are approximately equal. About 50%, 50.5% of the total cases have been men, 49.5% of the total cases have been women, majority being in that 25 to 49-year age group, 53%. Next slide, please. Among the fatalities, we do notice that there was a swing away from the overwhelming preponderance of men. We had seen about 75% of the deaths in previous times being men, and that has come down to just about or just over 60%. In this case, it's 60.7, and the female proportion should be 39.3. Small typo there. But what we notice is that the majority of those, again, are in that over 60 age group. We also have been making the point that many of these persons have had what we call comorbid conditions. That is, pre-existing disease that put them in a higher risk position for having a fatal outcome. Let's go to the next slide. When we look at this data in a little more detail, we look at among the men and among the women in each age group, the sorts of percentages in each age group that did have a comorbidity. We see that among the men, the percentage of the comorbidities were a little higher than among the women, and overall, that if you add up all the figures at the bottom, about 77% of that total number of persons who passed on would have had one comorbidity or another, with the comorbidities, that, as we said, being a little more common among the men than among the women. So the numbers here represent those admitting to comorbidities by age group. In some cases, there may not have been an answer, etc. So some of that data we still continue to pursue. But there have also been persons who did not have any comorbidities in both the older and the younger age groups. And this is something that we need to continue to emphasize, because even the absence of some pre-existing illness is not a guarantee that everything is going to be fine and you can ignore your infection. We still need to monitor any signs of infection very closely throughout the time period of your illness. Next slide, please. The other thing we look at, and we're showing two different sets of percentages here. We're showing the overall percentage among all reported deaths, whether we got information on comorbidities or not, and then just looking at those who actually reported comorbidities, what the proportion of those having different comorbidities happens to be. And we note that hypertension and diabetes were by far the most common of the comorbidities, and that the other things that were common but much less frequently reported were asthma, chronic obstructive pulmonary disease, that's the COPD up top, and IHD or ischemic heart disease, as well as malignancy, which refers to different kinds of cancers. There are a wide range of other things that fell into the other category, and the bottom line with the other column is that 72.6% of the people reported one or other of a wider range of comorbidities. So this is a recurring factor, some pre-existing illness in the persons who would have passed on. That brings me to the end of the epidemiologic update. We just want to make a couple important points. As we speak about the comorbidities, as we speak about those persons who would have passed on, we do want to emphasize again that sometimes people are not aware of their pre-existing comorbid conditions. People may not be aware that they have elevated blood pressure because they haven't been going to the doctor. Similarly for diabetes, similarly for a host of things that you may actually only discover if you have been regularly screening. So not knowing that you have a comorbidity is not the same as not having one. And again, it is really just to emphasize the importance of everyone taking the necessary precautions to avoid illness, not thinking that being in the younger age group is an automatic defense, and also being aware that when we are ill, when you have been diagnosed, as you monitor your condition, if anything changes, if you start to feel worse while you're home monitoring, the earlier you reach out for care, the earlier you reach out to the system to have yourself reassessed and, if necessary, admitted, then the better your chance of survival is. So it is not advisable to have a change in status and wait 2 or 3 days before you say, well, now I haven't been feeling better, let me go and make a phone call. Once things start to feel different, once you start to have increasing fatigue, increasing shortness of breath, decreasing pulse oximeter readings, those readings on that little machine that you put on your fingertip to see what your oxygen levels are, anything like that should trigger you reaching out to the system to get the necessary reassessment so that you improve your chances of survival. So that's one of the main clinical messages that we want to leave you with. The other clinical, or the other epidemiologic message is clearly that even as we see these numbers begin to come down, we do not want the population to believe that now is the time that we can relax and go back to what we were doing before. Now is the time that we need to hold to these public health restrictions, to the personal precautions that we've been speaking about with respect to the washing of hands, watching of distance, wearing of masks, especially when we're out and about, and also the wearing of masks in the household if you are ill. All of these things are the things that are going to help to reduce transmission from one person to another, either in a household or in the general spaces in the public that people occupy. And we need to continue to do this until the numbers continue their downward trend and until that circulation of virus is again very low. And we will continue to update the population on progress on that front. With that, I'd like to turn you over to Mr. Alexander.
And thank you very much, Dr. Hines. We now go to Dr. Alexander, who will speak on COVID-19 vaccines and their effects. Dr. Alexander.
Thank you. Good morning, Dr. Hines, Mr. Alexander, the members of the media, and members of the viewing and listening public. Today, I'll be talking to you about vaccination and what you should be aware of before and after. Slides, please. So, as I stated, we'll be talking about vaccination and what you'll be aware before and after. Next slide. And presently, the two vaccines that are involved in the vaccination rollout in Trinidad and Tobago are the Oxford AstraZeneca and the Sinopharm. And both of these vaccines are utilizing 2 doses to give their full efficacy. The time difference between the first and the second dose for the Oxford AstraZeneca is 8 to 12 weeks, while for the Sinopharm vaccine, it is 3 to 4 weeks. Next slide. So one of the questions that comes up is that a person has had their first shot or their first dose, and they want to know, is it necessary? Do I need to get the second one? Next slide. And the answer to that question is yes, you need to get the second dose. The efficacy that was seen in the clinical trials for these vaccines are based on the 2 doses that were received. And in fact, the clinical studies showed that there was increased efficacy between the 2 doses. So they looked at the results of the persons who had received that first dose and then compared it when the same persons received the second dose, and they saw increased percentages of neutralizing antibodies and other aspects of the immune system necessary to fight the SARS-CoV-2 virus. Next slide. So another question that comes up is, I've had both doses, now what? Now what can I do? What am I able to do? Next slide. And this is where we have to re-emphasize that you should still continue to follow the 3 W's. The wearing of the mask, the washing of your hands, and watching your social distancing. And let me emphasize, with the wearing of the mask, I should have put in wear a mask properly. It is not just a case of just having the mask on your face, but it is making sure that it covers both your nose and your mouth. Next slide. So persons ask, I'm vaccinated, I've gotten 2 doses. Why are we insisting that the 3 W's need to be followed? Next slide. And this is all about protection. It is one, protection for yourself. So after you have received that second dose, you are fully immunized 2 weeks after the second shot. And this has been shown in clinical studies done in the various trials for the vaccines. It is not a case of you've been fully immunized after that second dose. It is, there is a time period, and then you have full protection after 2 weeks after the second shot. So that is protection for yourself. So you need to keep following the 3 W's protocol. You are also, previous slide please, you're also protecting those persons who are not vaccinated. As of yesterday, the 15th of June, we have had 18,506 persons who have received both doses. If you look at this mathematically, this is approximately 1.3% of Trinidad and Tobago's entire population. So not a great percentage of our population has been fully vaccinated as yet. To maintain or to ensure that we decrease the spread of the SARS-CoV-2 virus until we have a greater number of our citizens being vaccinated, we need to continue following those 3 W protocols. And then we have to protect those who cannot be vaccinated at this time. Do remember that these vaccines, they are coded for persons who are 18 years and over. So we have the entire childhood population who cannot be vaccinated at this time, and they need to continue to be protected, along with those persons who have been advised due to medical reasons that they cannot take the vaccine. So the 3 W's needs to be followed to continue that protection. Next slide. So this might be a repeat or a re-emphasis, but we have to remember that to continue following the protocol of the 3 W's. We want to wear a face mask, and properly, as you can see in the diagram, it is covering both the nose and the mouth. We want to continue washing our hands, and we want to keep on with our social distancing. Thank you.
And thank you very much, Dr. Alexander, for that timely presentation. We go back to Dr. Hines for some additional information.
Okay, thank you, Mr. Alexander. One of the things that I wanted to add to Dr. Alexander's whys, in terms of why we want to continue with the personal precautions, is really again about reducing risk at both a personal and a public health or population level. So while we build up a larger group of persons within the population that is fully vaccinated, the other things that we are doing, even as a fully vaccinated person, to ensure that we aren't potentially still carrying and spreading the virus, because it is still possible, although much less likely, it is still possible that an infection can happen. It would be a much less severe, possibly unnoticeable infection, and for that reason we still want to ensure that people know that they're not 100% COVID proof, and therefore they still need to be aware that they need to reduce the risk of sharing unknown infection with their family members, either with their kids who can't be vaccinated or with their older family members who are at higher risk of adverse outcomes. So that personal responsibility doesn't disappear when you're vaccinated. We need to ensure that we all hold all the layers together, the vaccination, the public health measures, until such time as we get the level of circulating virus back down to a low level when you can consider making changes. It's just an emphasis on what Dr. Alexander would have spoken about, and to remind everyone that we all need to do our part. We all need to hold the fort together in order to get this under control.
Thank you very much, Dr. Hines. As we move into the question and answer segment, we remind our media representatives to pose their questions to members of the panel and state their name and media house. Because our time is limited, we are requesting a maximum of 2 questions per media house in the first instance. If we do have more time for questions, we will take it once we have extra time. We now go to the Express. Good morning, Express. Okay. We will come back to the Express and we'll go to TTT. Mr. Lala, we are ready for your question. Good morning.
Hi, good morning. Sonal Lala, TTT News. Question, I think, to Dr. Hines. We got a question from someone. It's a woman who took the first dose of the vaccine, but she became positive for COVID, and she now has to wait at least 3 months to get that second dose. Now, given that the AstraZeneca is reported to end on July 9th or so on, will it be available in August when she is due to return for that second dose, as well as many others, I suspect, and to Dr. Hines as well? What have we seen in terms of the population, in terms of communities? Where is the, I know we haven't seen an epidemiological map for just a few sessions, but which communities are we seeing it? Is it going down in specific communities? Is there a high presence in certain communities with COVID as well?
Okay, thank you for the 2 questions. Now, we do need to bear in mind or remember that there are subsequent batches of the AstraZeneca vaccine that will be coming in, so that the persons who have to delay or wait until the 3-month time period has passed should still be assured that the vaccine will be available at the point in time when they need to get their second dose. With respect to the geographic spread, at this point in time, when there's still a fairly large number of cases across the population, we don't note too many high and low points. We have ongoing transmission in the majority of the what we call population centers, those towns that are densely populated. We continue to see numbers there, although the numbers overall may be decreasing. We are not yet in a position to say that any one community has gone down more significantly than the other, but as we continue to compile the information, those updates will be brought to your attention. The important thing to remember, however, is that the level of positivity or the number of cases in your community is not necessarily directly related to your risk, because your risk is not necessarily tied to where you live or who else in your community may be infected, but it's more related to your personal and social webs of contact, which may very well extend outside your community. So one of the things that we do want to continue to remind people of is that looking at the community spread doesn't say, okay, if I live here and there are fewer cases here, then I'm safe. Our very mobile population, or very connected population, means that we have contact webs where somebody in Diego Martin may be working with somebody that lives in Sangre Grande. So where somebody who lives in Point Fortin may be working with somebody who lives in Arima. We have that kind of mobility, and because of that, the mere geographic distribution is not a direct relation to your personal risk, and we don't want people to think that if they have fewer numbers in their community, then they're somehow protected by that by itself. When we get the entire population levels to be lower, that is the protection that we are really looking at and looking forward to.
Thank you very much, Dr. Hines. We go back to the Express.
Good morning, Kim Boudreau from the Express. So sorry about that glitch just now. Dr. Hines, I'm going to ask you to revisit the Pfizer issue that came up at the weekend and the 80 vials that would have come in as a donation from the United States to the Ministry of National Security. Would you be able to update us as to whether or not those have been cleared, meaning whether or not the relevant documents have been received, processed, and whether or not the product has been cleared for use and handed over to the Ministry of National Security? And could you tell us when they will be administered to personnel in that government agency? Would that be happening from today? Thank you.
Okay, thank you for your questions. And the answer to the first is yes, documentation was received and the vaccines have been handed over to the relevant ministry. And it is expected that their distribution of those vaccines should begin today.
Thank you very much. We now go to I-95.5 for your two questions.
Good morning to all of you. Whitfield Turner from I-95.5. I'm not sure which of the doctors would take my first question. It's in regards to the shortening of the time between infection and vaccination from 6 months to 3 months. Does this mean that the natural immunity is not as long-lasting as we would have originally thought? That's my first question. And Dr. Hines, I believe you'll be able to answer my second question and to bring clarity to this matter. Should a family be put in quarantine once one member of the household tests positive, or would they only be put in quarantine if there are multiple positives or if the positive case turns symptomatic? Just wanted to get that issue clarified. Thank you.
Okay, thank you for the two questions. I'll actually go to the second one first. At this point in time, one of the key strategies that is being employed to reduce or to get ahead of chains of infection is that if a positive is identified within a family, the other members of the family are considered to be what we call primary contacts. And we don't necessarily have to wait until another one of them is positive or even symptomatic before they are quarantined. The quarantine of well people in a household with an infected case is really a mechanism for preventing asymptomatic people from going about and having the potential to spread illness even though they don't know that they're infected. So we do use that strategy of quarantining primary contacts within the household in the absence of symptoms and in the absence of another positive test within that family. So hopefully that clarifies that. Now, the shortening of that time period is something that this is with regard to the first question. The shortening of the time period for vaccination is really with regard to what the consensus of scientific literature has shown to be both safe and effective with regard to the administration of that second dose. So it does not mean that the natural immunity is shortened per se, but we do know that the current scientific consensus is that the immunity that is derived from the vaccination, that immune response is a bit more robust than just the response that you may get from different kinds of dosing in a natural infection setting. So we do want to encourage people who have been vaccinated, even if they do get that illness in between, to follow up and get their second dose at the appointed time, so that the immune response can be optimized and we reduce risk of further complications.
Thank you very much. Great question. We now go to IETV.
Good morning, Peter Mickey's IETV News. I have two questions. Perhaps Dr. Hines may be able to address it. Dr. Hines, can you give us an update on the regular healthcare system? Are people still seeking treatment for minor illnesses or minor incidents as compared to before the before the pandemic, or are they perhaps fearful of what's happening? And secondly, when can we expect persons with comorbidities to be accommodated for the vaccines now that the Ministry of Health has rolled back to only persons over 65? Thank you.
Okay, thank you for the two questions. Now, while I don't have a numerical update on the functioning within the general healthcare system, the general healthcare system does continue to function and continue to provide healthcare for persons with non-COVID related illness as it has in the past. We did note that there was, especially last year, more of a decrease in the number of persons that were seeking care at that point in time. We had spoken about it and encouraged those, especially those with pre-existing comorbid conditions, to continue to do their follow-up, continue to take their medication so they can keep their comorbid conditions under control. We again want to make that appeal. All the individuals that would have belonged to various clinics, once the clinics have changed some of their functioning to allow for continuation of your meds, etc., we do want to encourage people to continue to keep their comorbid conditions under control, as that is one of the things that helps to reduce risk of adverse outcomes if you do happen to then become infected with COVID-19. So yes, the system is functioning. It seems to be accessed on a fairly regular basis for the routine concerns, and we want to encourage the population to continue to do that in the way that they have been before and as necessary to maintain control. Now, the next question, the one is really contingent upon the availability of additional vaccines in the system, and as those vaccines roll into the system, they're rolled out into people's arms. When the next phase, so to speak, of that rollout begins, that will be notified. We will say, okay, now we're dealing with this next group of individuals. So that information will be brought to the attention of the public as soon as. But at this point in time, with the vaccines that we currently have, the system and the target group that we currently are looking at remains in force.
Thank you very much, Dr. Hines. We are going to AZP News for the next questions.
Hi, good morning. This is Suan Wire from AZP News. With respect to younger persons contracting COVID-19 and dying, has the ministry done a proper assessment to know exactly how many people under 30 or under 40 have passed away in 2020 and into 21, and was COVID-19 the primary cause? And my second question is, does the ministry have any solid data to show how many local citizens have contracted COVID-19 so far compared to foreigners and perhaps those who are not legally registered? And if not, kind of comprehensive breakdown, please be provided soon. Thank you very much.
Okay, thank you for that. Now, you would have seen where some of the data that we've provided has gone into those additional age groups. We can, the slide that we presented earlier had the under 50 age group. We can then disaggregate that further. So yes, we do have a full count of all the people by age and by age group that have passed on. And you do see that in the pyramid of the fatalities. So that second pyramid that we show does demonstrate the proportion of and the underlying numbers for those people who are under 30. Where COVID-19 the underlying cause in all of them? Not always, and that is because we have opted to count all deaths with COVID-19 among the COVID-19 statistics, even some that may show up in the system with other issues that may have contributed to their demise. So we are opting to be a little more inclusive as opposed to exclusive with respect to how we count the deaths, especially in the younger age groups. With regard to the next question, the data on the nationality of the patients isn't always data that comes all the way to the level of the epi division. I'm not necessarily certain that the data on the nationality of patients is something that is routinely collected and documented, for the simple reason that our public healthcare system provides healthcare to whoever comes to it. So the completeness of that data I can't necessarily speak to. I do believe that somewhere in the notes there will be the documentation of nationality, etc., but it may not be stuff that is collated and sent forward or sent up the chain. The ability to do that and the time that would take to do that may be protracted, but at any point that information becomes sufficiently complete, then we'll be able to share that disaggregation when that happens. I believe I've answered all the questions or the parts of the question.
I think you have. Thank you very much, Dr. Hines, and thank you for your questions. We now go to CL Communications.
Hi, good morning. I just wanted to find out, well, first things first, Natalie Singh, Caribbean Lifestyle Communications. Based on what's happening overseas concerning the Sinopharm vaccine, is the ministry looking at doing perhaps a third shot of the Sinopharm vaccines to those who have already received it and who would not have gotten up to the immunity level that they speak about? And then my second question is also, is the Ministry of Health testing people who receive the Sinopharm vaccines to find out whether people are developing the antibodies at the level of where it's supposed to be at? Thank you.
Okay, thank you for the two questions. That is a ruling bit of scientific observation and collation, which the Ministry of Health is observing. If at any point in time the recommendation from the WHO level becomes a recommendation for additional vaccinations within a given time frame, then the current scheduling will be changed accordingly. At this point in time, the ministry's resources aren't being utilized to double-check the what we call antibody levels, looking at the level of immune response in individuals. But we will continue to monitor the overall impact of all of the strategies, vaccination, public health measures, etc., on the transmission of illness and the numbers of cases that we see. So overall impact really is not just the vaccination and antibody levels, but all of the things that contribute to the decrease in cases that we're working towards. And to the extent that we see that happening, we will continue what we're doing. So hopefully, again, that answers the two questions you've asked.
Thank you very much, Dr. Hines. We now go to TV6. Good morning.
Okay. TV6, thank you for the opportunity to join you all once again. Dr. Hines, in the height of the recent wave, let's use the middle of May as a gauge. We asked why there were so many deaths. At that point, you told us that because the number of cases were high, around that time there were about 600 cases per day. You said because the number of cases were high, serious cases, the need for hospitalization would increase and therefore deaths would increase. But of course, if we look at the infection fatality rate, which, as you know, is the number of deaths per infections, around that time, it was about 3.8%, or like 23 deaths per 600 people. But over the past 2 weeks, we're still seeing a high number of deaths despite infections being having gone down. For instance, we had 16 deaths for 412 cases. 3 days ago, we had 14 deaths for 301 cases, which was a daily infection fatality rate of 4.6%, even higher than during that peak. Given that explanation, well, from the evidence, it doesn't hold, can you tell us why still so many people are dying? That's the first question. Secondly, we saw the CDC and the Color of Coronavirus projects and other studies across the world looking at the analysis of deaths by race and ethnicity. What do your studies show on this analysis? That is one group suffering more than others via deaths or serious cases than others? Thank you.
Okay, thank you for your two questions. Now, the first issue with your analysis is the fact that when we do what we call the case fatality rate, we're not looking at the number of deaths reported on a given day against the number of infections reported on that day. To make the point more clear, the number of infections reported on a day does not necessarily relate to the number of deaths on that day, because the people that may have died on a given day aren't the people necessarily infected on that day, which is why we do what we call a cumulative case fatality rate between the start of the infection in the population and any given date. Overall, how many people have been infected, and then overall, how many people have died. And the reason for that is that it does take some time between your infection and the eventual outcome, whether it is survival or a fatality. So when you count the number of people infected on a given day and then use the number of deaths on that day as your numerator, your calculation is invalid. So going back to what we said before, the number of cases that we've seen in the month of May, looking at just the month of May by itself, we got over 13,000 cases. That number of cases would generate a certain number of fatalities just based on the probability of death from COVID-19. As the number of new cases decreases, there's also what is known or what has been observed as a lag between number of cases and then the peak in deaths. The peak in deaths does not coincide with the peak in the number of new cases. So what you would have seen, especially at the start of May, the early part of May, is that there was actually a decrease in that case fatality rate because the denominator was increasing, but there weren't deaths happening at that point in time. And conversely, as the number of new cases decreases, the number of active cases still in the system and awaiting an outcome slows at a different pace. So you still have active cases still being treated, lives are still being worked on, the attempt to save lives is still happening. And while that is happening with those active cases, the deaths that come out of the system do lag in terms of the rate of decrease until such time as the system stabilizes again. So it is completely incorrect to say that the explanation doesn't hold. The calculation that you provided is not the correct one. Now, the second question with respect to ethnicity. Ethnicity at the US and to some extent the UK health system has a particular connotation with respect to access to healthcare, with respect to socioeconomic variables, things that actually impact on health outcomes. That is not necessarily the driving factor in our particular situation where our public health system basically accommodates anybody who can access it. So looking at the way that the analysis of ethnicity and fatality in the American population by the CDC, the UK population via Public Health England, we're looking at that comparison, trying to map it to our population, to our situation, is actually not a valid comparison either. Added to which, the ethnicity of all the patients that we've seen largely just mirrors the ethnic mix in the population. We have not necessarily collected all the ethnicity variables on each individual patient all the way up to the national level. That again is information that is being retrospectively filled in and sought so that at some point retrospectively we'll be able to say whether there was any significant difference. But there isn't expected to be one based on the same sort of criteria used by CDC or PHE, because their socioeconomic links to ethnic groups are very different from ours. And this is a question that has been asked before. We have explained it before, but thank you for the opportunity to explain it once again.
Thank you very much for your question, and Dr. Hines for your response. We now go to the Newsday for your two questions. Good morning.
Good morning, everyone. Rihanna McKenzie here from Newsday. My first question is actually from a member of the public who would like to know if it's possible to give blood after being vaccinated. My second question, Dr. John Paul on Monday warned of the potential increase in cases of MIS-C, multisystem inflammatory syndrome in children. On Monday, the number of recorded cases, I believe, was 40. I was just wondering if we can have an update on that figure, please. Thank you.
Okay, thank you for the questions. I'll actually pass the first question to Dr. Alexander with respect to whether you can donate blood after having been vaccinated.
Hi, good morning. I believe there isn't any real reason why you cannot donate blood after vaccination. Obviously, once vaccinated, if you are having any mild side effects, you would not go and volunteer to donate blood at that point in time. You want to make sure that you are feeling well. And also, once you go to the blood bank, you would inform them that you have received the vaccine. And when you received both the first and the second dose, and then they can advise you as such. Thank you.
Okay, thank you. And with respect to the question on Ms. C, between the last update by Dr. Paul and now, we have not received any additional notifications of any new cases. The point that Dr. Paul made was that after the peak of an epidemic in a population, the adult population, we do see a lag between that and what may show up as Ms. C in the pediatric population, and therefore we continue to monitor. Not that we're actually seeing an increase at this point in time, but that we do continue to monitor. And as additional information becomes available, we will provide those updates in subsequent press conferences.
Thank you very much. And you know, doctors, on Monday last was World Blood Donor Day.
Yes.
Yes. And so we would want to encourage our population to continue to give blood. We now go to Mr. Rashad Khan of the Guardian Media Limited. We're ready for your question.
Hi, good day. Actually, it's Renuka Singh at The Guardian. I'm trying to get some figures as to how many persons, if we have those figures, that is, how many persons would have died from COVID at home versus those was calculated at the state-designated health facilities. And do we have any data as to how many of those fatalities took place at the ICU/HDU? Thank you.
Okay, so the data we have at our disposal suggests that the distribution of locations is approximately 7% of the, or 6.9% of those fatalities may have occurred at home, whereas the vast majority would have occurred within the parallel system. There were a couple that we would have identified out of our continuing monitoring of forensic deaths, meaning that's actually from external causes, but swabbed subsequently for COVID-19 and found to be positive. Very small numbers, maybe 3 or 4. And then some that would have entered the accident and emergency systems within the public hospitals and were severely ill and therefore did not survive the transfer from accident and emergency to the parallel healthcare system, somewhere in the vicinity of about 26% or so. So that is the sort of overall proportion that we're looking at. And we continue to monitor, we continue to update, and we also continue to seek retrospective data where it may not be available at national level. With regard to the ICU versus HDU, again, this is information that is being compiled, that the information that currently reaches us isn't always tagged with which level of care was involved at the time of death. So that is something that we are backfilling, retrospectively going back and making sure that we have all the data before we give a proportion, because the proportions can be skewed by which data you do get. So we will give that information at a subsequent point in time, bearing in mind and giving the caveat up front, of course, that the need for ICU and HDU care in the first place obviously represents the presence of much more severe illness, and therefore the possibility of a fatal outcome within the ICU and HDU settings would be higher. So when we get a fuller set of data that represents the fatalities, we will be able to give a reliable proportion, and we endeavor to give that information to you in the shortest time possible.
Thank you very much, Dr. Hines. We do have time for a few more questions, so we will take one brief question per media house as we proceed, and we go back to AZP for the follow-up question.
Hi again, but I believe that Whitfield had his hand up, so I don't mind if he goes before me. He had his hand up from the first round, please.
You pose your question and then we'll go back to Mr. Turner. Thank you.
Yes, thank you very much. A question coming in from a member of the public. They are asking if it's safe to consume alcohol after taking the vaccine.
I have heard that question before. Thank you for the question. I keep meaning to actually bring this up. Not on the day that you take the vaccine. Give it a couple of days. It is not that once you've taken the vaccine, you're banned from alcohol forever. I'm hoping that's not discouraging people from being vaccinated. Yes, you can drink, just not on the day or two after. Okay, so don't let that discourage you.
Okay, thank you very much. And we go to I-95.5.
You just had me, so you can go to AZP.
That's what we're trying to do.
Hello, good morning again. So my question would be, the Sinopharm vaccine has WHO's approval to be administered to pregnant women, but we are not yet doing that here in Trinidad and Tobago. Given that second doses of this vaccine have already begun rolling out, can the ministry say exactly why it is withholding this vaccine from that particular group? Thank you.
Okay, so the authorization to utilize the vaccine in pregnant women is still something that the data is being collected on. Yes, it has been authorized, but at the same point in time, the data set and the actual evidence that supports that decision still is in a relatively small number of individuals, and we are doing what you call erring on the side of caution with regard to not exposing pregnant women to a new product without a little more robust information within the healthcare system. As more information becomes available, then that decision will be reviewed and it will be updated as needed.
Thank you, Dr. Hines. From time to time, we do receive questions from the public, and we do have some frequently asked questions. The first one is, if a person has an allergic reaction to food and drugs, is it safe for them to get the COVID-19 vaccine? I'm asking Dr. Alexander to respond to that question.
Hi, good morning again. So do remember, when someone has allergies, it is usually to one specific item per se. So you said here food and drugs, that covers a wide variety subjects. With respect to the COVID-19 vaccines, when the vaccines first came out, it was advised that persons who had allergies to vaccines in the past were cautioned with respect to taking the vaccine, because there are some common components that are usually found in all vaccines. So it was believed that if you had allergies to vaccines in the past, you might have an allergic reaction to these vaccines. There have also been persons who are allergic to a particular component of the vaccines, and so they have been advised not to take the vaccine. What I would advise is you speak with your healthcare professional with respect to what your specific allergies are with respect to the COVID-19 vaccines. And there have been case studies where persons who have allergies, not necessarily allergies to the components of the vaccine, but just general allergies, have taken the vaccines. And what has been advised in their cases is that they followed the period of 30 to 60 minutes of waiting at the healthcare centers to see if an allergic reaction occurs, since it normally occurs within that time period. And this is something that is being done presently with everyone who receives the vaccines. So it is not a straight, clear-cut answer. If you have allergies to food and drugs, it means you cannot. It means you need to consult with your healthcare professional with respect to if you should take the vaccine.
Thank you very much, Dr. Alexander. Dr. Hines, the next question goes to you. If I don't have side effects from the COVID-19 vaccine, does it mean that the vaccine does not work?
Okay, thanks. That's a good question also. Now, the short answer is no, it does not mean that. If you don't have what we call those constitutional side effects, feeling fatigue or fever or whatnot, it just means that your immune response did not then make you feel unwell. Not feeling unwell does not mean that your immune response wasn't present. It doesn't mean the immune response was weak. It just means that constitutionally, the way your body is put together, that immune response didn't trigger a feeling of unwellness within your system, but it is working, and it is not a reason to doubt the efficacy of the vaccine. So thanks for the opportunity to clarify that.
Okay, and we have a follow-up question. Is it okay for persons in a household to get different brands of the COVID-19 vaccine, or should they all get the same brand?
It is okay. The simple answer is yes, it is okay for persons in the same household to get the different types of vaccines. We ultimately want everyone to be protected, and this is why we urge you take the vaccine that is in front of you. There should be no other reason that you worry if your mother, father, spouse received the Oxford AstraZeneca, for example, and you're receiving the Sinopharm, that there should be a problem. Everyone can still live in the same household even if they took different types of vaccines. Also, I just wanted to do a follow-up on the question that Dr. Hines had regarding the side effects. If you don't have side effects, does it mean your immune system isn't working? What the clinical studies also showed is that they compared the immune response in persons who had no side effects after receiving the vaccines versus those who had, and they had comparable immune responses. So everyone's immune system reacts differently. Just because you are not exhibiting any side effects doesn't mean you do not have a very effective immune response.
Okay, so we may have time for just one more question. So TV6.
Hi, just a point of clarification from Dr. Hines. Is it that deaths in your estimation have decreased? One, yeah, that's the point of clarification. And the other question was excess deaths. Could you give us an idea of excess deaths?
Okay, so I'm not sure where in what I said you got the impression that deaths decreased. I did explain that there is a lag between the decrease in the numbers of cases that you see, as in between the peak of the infections and the peak in the deaths. So we're continuing to monitor. We're aware that you have active cases that still have to have an outcome and that there may be fatalities out of those. With respect to excess deaths, we're actually doing that analysis. We did have information up to April which suggested that we didn't necessarily have any excess of deaths above what's expected. We are analyzing the data from May, where we do expect that we would see, as a result of the number of cases that we had and the number of deaths that arose out of it, that we expect to see a change in May, and we will actually bring that data to one of these conferences as soon as we've finished making an in-depth analysis of it.
Thank you very much, Dr. Hines. TTT.
Hi, good morning again, Sonolala, TTT. Dr. Hines, I'm not sure if we have any figures. I know prior to COVID, we would have gotten updated figures in terms of influenza numbers. The influenza season would have just finished in May. Do we have any figures in terms of how many deaths there would have been due to influenza, or has COVID somewhat hampered?
Okay, so short answer is that the sort of testing capacity that is currently being utilized to do the COVID testing has to some extent hampered some of the other respiratory panel analyses, but we have not seen any worrying change in the number of influenza-like illness outside of COVID. Most of what we're seeing from the respiratory perspective, from the clinical perspective, and from the laboratory perspective seems to be more COVID than anything else at this point in time. And the testing for other respiratory viruses has, quite correctly, been hampered to some extent by the resource allocation to the large-scale COVID testing. So we're monitoring, and if we see anything that is unusual or worrisome, then the public will most certainly be alerted, but that's not the case at this point in time.
And thank you very much, Dr. Hines and Dr. Alexander. Ladies and gentlemen, we have come to the end of today's media conference. Thank you for sharing your time with us. Please note the vaccination rollout has recommenced today for persons 65 years old and over. We continue to recognize and thank the public for their continued support and participation in this fight against COVID. Remember, to be fully vaccinated means that you have the full defense mechanism to fight the virus, which usually takes about 2 weeks after your second dose. And even though you are fully vaccinated, you still need to practice the 3 W's to continue to protect yourself and others. That is, wash your hands, watch your distance, and wear a mask. Have a good day, everyone, and stay safe. Goodbye for now.